Hoping that without any technical issues, we may go ahead. A warm welcome to everybody. Today, we are going to conduct a webinar from the Department of Obstetrics and Gynecology of Yenepoya Homeopathic Medical College related to the topic on obstetrics and gynecology, the topic being the role of homeopathy in third trimester of pregnancy. As it is, we have known these areas of pregnancies are not much explored through homeopathy, and the problems which we as a homeopaths face up during our clinical practices are not easily able to be managed at the initial part of our practices. Hence, the topic is being selected so that though already in practice, it can be a better way to learn something more, or might be for the youngsters who are going to join up in their practical or in their clinical practices, they can try to go ahead with more of comforts and more of confidence. And hence, the topic is being selected. And today, we are having one of the best speakers related to the subject itself. And to welcome the speaker, to give a brief introduction about the speaker, I myself, Dr. Kiran Kamar, HOD Professor from the Department of Obstetrics and Gynecology of Yenepoya Homeopathic Medical College, I request Dr. Ashna Suresh, Assistant Professor, Department of Obstetrics and Gynecology from Yenepoya Homeopathic Medical College, to give a brief introduction about our speaker and to welcome her. Over to Dr. Ashna.
Good afternoon to everyone. I'm privileged to introduce the resource person of today's webinar, Dr. Harsha Kantode. Ma'am is a principal of Homeopathic Medical College and Hospital, Gondia. She is also the head of Department of Obstetrics and Gynecology there. Ma'am has 22 years of teaching experiences, coupled with 23 years of professional experience too. She worked in Government Homeopathic Medical College, Bhopal for 3 years, associated with many non-government organizations for the prevention of COVID-19. She is a senior homeopathic physician of Gondia City. So, with this brief introduction, I would like to extend a warm welcome to ma'am. Over to you, ma'am.
A very good afternoon to all the dignitaries present in the Yenepoya Homeopathic Medical College, Mangaluru. I feel quite privileged that you called me to speak upon this subject of role of homeopathy in third trimester of pregnancy. I hope we will learn a lot from today's topic, today's talk. We will talk about the uh, what the physiology in the third trimester, what happens in the third trimester, and then when we understand everything about the third trimester, then we will go to the therapeutic part of it or the homeopathic part of it. uh, I think we will start with the topic now.
Yes, ma'am, you can go ahead, ma'am.
Okay. So as the first slide is telling us that about the topic, that it is the role of homeopathy in the third trimester. So first of all, we should understand what is third trimester. As we all know that the pregnancy consists of 9 months or 280 days, and embryologists used to subtract 14 days from 280 days, and thus they say that 266 days are proper days of pregnancy. So if we divide these 266 days into 3 equal phases, it will come 88.6 or 89 days, 89, 89 and 88 days, like that. So we have made the period of 3 months. First 3 months are first trimester, second 3 months are second trimester, and third 3 months, that is from week 29 to week 40, as the slide itself is showing. It is from 7th, 8th and 9th month of the pregnancy is the last phase of pregnancy, and it is called the third trimester. Okay. Now about the development in the third trimester. What kind of fetal development will be there in the third trimester? As we all know that pregnancy is the period where the fastest growth in our life happens in the intrauterine life. When the single cell will get converted into a big baby, so 50 to 52 centimeter growth, it requires a lot of time extrauterine, but in intrauterine life it takes a very little time. In 9 months, in mere 9 months, one single cell will get converted into a 50 to 52 centimeters baby. So the growth is very very fast, especially when we talk about the third trimester. In the third trimester, the fetus continues to grow in size as well as in weight, because most of the organs have already formed. Now the size and the weight of the baby will increase in the third trimester. The lungs are still maturing, and that's why when we suspect that in third trimester, if we suspect that there may be prematurity or there may be preterm labor, they used to the management part of the third trimester, when we suspect early evacuation of the baby, we used to give some drugs to let the lung mature fast, because lung maturity is the most important event which takes place in the third trimester. And there are other events also. If the baby is male, the testicle will descend down to the inguinal ring in about 28th week, at the end of 28th week. And from 20, at the 20 at 36th week, the testicle usually recedes down. At least one of the testicle will recede down in the scrotum. And by the end of the third trimester, the weight of the baby is in between 2.7 to 3.1 in India. uh, as we all know, in every country the weight of the baby will differ. In India it is said to be 2.9 kg average weight of the baby, and the length is 50 to 52 centimeters. Length is more reliable criteria about the maturity of the baby than the weight of the baby. Next slide please. Next slide. Thank you. uh, about the symptomatology in the third trimester. Symptoms are, as the diagnosis of pregnancy itself tells us, the symptoms of pregnancy are the first and the foremost symptom is amenorrhea. Amenorrhea will be a persistent symptom from right from the first trimester to the third. At the end of the third trimester, amenorrhea will be persistent. Second thing is enlargement of abdomen. In the first trimester, there is no enlargement in the abdomen. In the second trimester, a little bit enlargement from the pelvic cavity to the abdominal cavity, and this enlargement will be more pronounced and more progressive and can be very easily elicited, because the enlargement of abdomen is progressive, with which produces some discomfort such as palpation, dyspnea following exertion. As the uterus becomes an intra-abdominal organ, full intra-abdominal organ, and the fetus is growing like anything, and because of that, the intra-abdominal pressure, as well as it will go and increase the intrathoracic pressure also, because it will shift the diaphragm a little bit towards the thorax, and that will lead to little bit of dyspnea and palpitation to the patient. At the third trimester, at the end of the third trimester, we will have a little bit when the baby will descend down. The baby will descend down because at the age of 36 week, it will touch the ensiform cartilage, that is the xiphisternum. And afterwards, at the when the after 36 week, when the baby will grow, so the uterus will come down, because the presenting part will enter into the pelvic cavity. And once it will enter into the pelvic cavity, the fundal height of the uterus will recede down. In the next slide, we will see how it is receding down and how the girth of the abdomen will increase, because the uterus will come down. Then that the when the uterus when the level of the fundus of uterus will recede little bit down, the patient will feel lightening. Lightening means she'll feel little bit light, because she can take a deep breath as the uterus has came down. Why the uterus came down? Because the presenting part has entered into the pelvic brief. So when the fetal part enter into the pelvic cavity, the intra-abdominal pressure will also reduce, thus reducing the intrathoracic pressure, and thus the patient will feel a little bit comfort. And the dyspnea and the palpitation will recede down little bit. As soon as the presenting part will enter into the pelvic cavity, there will be appearance of frequency of micturition, because this presenting part will go and pressurize the bladder of the uterus. Once it will go and pressurize the bladder of the uterus, there will be frequency of micturition. Frequency of micturition is the symptom in the first trimester also. In the first trimester, because of the development of the fetus in the fundus of the fundus of uterus will pressurize the bladder, and thus there will be frequency of micturition. Now this frequency of micturition will completely gone in the second trimester, but it will reappear in the third trimester. Okay, so when it will reappear in the third trimester, it is because the presenting part has entered into the pelvic cavity and it is going and pressurizing the bladder, and because of that there will be frequency of micturition in the last trimester also. Then the fetal movements are more pronounced. The fetal movements can be elicited from the second trimester itself, but in the third trimester the fetal movements will be more pronounced. We can actually visualize if the lady is thin, and when you take the patient for an ANC checkup, when you make the patient lie comfortably in supine position, and when you expose the abdomen, we at times see that the fetus is moving. So it is very pronounced, and we can very easily discriminate the fetal parts, the fetal position, the lie, the presentation, everything. Next slide, please. Now about the signs of the uh, third trimester. In the second trimester also we will have cutaneous changes because the skin is stretched. There are appearance of pigmentation striae, that is linea nigra will be seen. This is a hyperpigmented line, midline drawn on the abdomen because of the hyperpigmentation, which can be very nicely elicited in the third trimester also. Then the next is uterine shape. The change in shape will change because up till 36 week the uterus is growing progressively towards from the symphysis pubis to the umbilicus to the ensiform cartilage. Once it has reached up to the ensiform cartilage, that is at the age of 36 week, after that the just in the previous slide I told you that the presenting part will recede down into the pelvic cavity, and as it recedes down in the pelvic cavity, the uterine ovoid which is maintained throughout the 36 weeks of pregnancy will get disrupted. The uterus will become barrel shape. That ovoid will no more be seen after 36 week. So the uterus will recede down to the 32 weeks level, but the shape of the uterus will change. That we are going to see in the next slide. Then the Braxton Hicks contractions are very nicely evident. Braxton Hicks contractions are the contractions which are going throughout the pregnancy. If you put your palm on the uterus of an ANC lady, you will feel that something is crawling below your hand, and that crawling is nothing but the contractions and relaxations of uterus. It is a rhythmic contraction and relaxation of uterus which is going out throughout the pregnancy, and which we have seen in the placental circulation. It helps in the placental circulation. It helps in so many other ways. So these contractions can be very nicely evident in the third trimester because the uterus is in its full strength. It is extended to its full strength. So you can very easily uh, elicit or evidence of Braxton Hicks contractions. Then the next and most important thing, that is fetal heart sound, can be heard. Fetal heart sound can be heard in the second trimester also. In the third trimester, we can very easily, when the baby will change its position, the fetal heart sound will shift towards another portion of the uterus. So this sort of fetal heart sound can be very distinctly heard, and we can actually palpate the back of the baby, the anterior shoulder of the baby, and keep our stato on the scapula of the baby and hear it very distinctly and count it. It is very important to differentiate the fetal, to hear the fetal heart sound and differentiate the fetal heart sound from any other sounds in the uterus, because there are some other sounds also which we can hear on the uterus, that is the uterine artery shuffle. When the uterine artery supply the blood to the uterus, there are pulsations in the uterine artery which can be heard, and can get we can get very easily confused whether we are hearing the fetal heart sound or the uterine shuffle. So to differentiate between these uterine shuffle and the fetal heart sound, there is one trick which we usually perform. When we put the stato on the earpiece on the abdomen, we used to put our hand on the radial pulse of the mother. If the fetal heart sound which we hear from the stato is coinciding with the maternal pulse, so that is not a fetal heart sound, that is the maternal circulation, that is the uterine shuffle. And if it is not coinciding, when you hear the sound, you are not feeling the pulse, then it is a fetal heart sound. And the classical sound of the fetal heart, that is the, when you it is written in the book that when you put a ticking clock below your pillow and you put your head on the pillow, what you hear is the fetal heart sound, that proper tick tick of the clock, that buzz of the clock. Okay, so that is the fetal heart sound. So there are so many other methods also, and with experience we will learn that what is fetal heart sound and which one is uterine shuffle. Then the next is palpation of the fetal parts. As in the previous slide also I told you that it is very easy to identify the fetal parts, especially when the patient is thin. If the patient is bulky, it is quite difficult, and if it is a occipito posterior position, it is again difficult to feel the fetal parts. But usually in a normal pregnancy, we can identify the fetal parts very easily. Next slide please. Next slide. Very difficult to learn. Next slide. Fundal height. Just now I told you that the fundal height of uh, uh, the uterine fundal height which we measure during the third trimester, when we examine the patient in the third trimester, uh, that is the third trimester starts from the 28th to 40th week. You can very easily see on the slide that after 28th week to 36th week, the uterus is enlarging towards the ensiform cartilage, and after 36th week, at the level of at the age of 40 weeks, you can see there is a dotted line which is seen on the slide. At the age of 40, the uterus will recede down to the 32 weeks level. Okay. 32 weeks level. When it is why it is coming down to the 32 weeks level? Because the head or the presenting part has entered the pelvic beam, and because of that the uterus has came down. As it came down, you can see the shape of the uterus has changed. Okay, that uterine ovoid cannot be seen anymore. It has become barrel shaped. So this is how we differentiate when the uterus is felt on the 32 weeks level, whether this pregnancy is of 32 weeks or whether this pregnancy is of 40 weeks. If the patient forgets the date of the LMP, it is very difficult to know whether the lady is having 32 weeks of pregnancy or 40 weeks of pregnancy. Okay. So with the shape of the uterus, we can very easily differentiate the weeks of the pregnancy, and with the history and development and all that, we can very easily differentiate. So fundal height is very important thing to uh, elicit and to measure and to know the condition of the fetus inside. inside the uterus. So at 32 weeks, junction of the upper third and middle third of the umbilicus and ensiform cartilage. At 36 week, up to the level of ensiform cartilage, and at 40 week, it comes down to 32 weeks level because of engagement of the presenting part. Okay, next slide please. Now, examination and findings in the third trimester of pregnancy. So, what we when the patient came to us for the first time in the third trimester, so what kind of information we will need for the management of the case. The abdominal examination is needed. A thorough systemic abdominal examination beyond 28 week of pregnancy can reasonably diagnose the lie, the presentation, the position and the attitude of the fetus. What is lie? It is the relationship of maternal spine with the fetal axis. Okay. When the maternal spine lies perpendicular with the fetal spine, it is transverse. When it lies parallel, it is longitudinal lie. So this sort of thing. Then presentation means the part which overlies the lower uterine segment, or the part which comes on in the lower part of uterus. Usually it is the skull. Okay. Then the position is when uh, the head, to which pelvic quadrant the head belongs. Okay. When the head is the presenting part, commonly head is the presenting part. So for knowing the position, we make denominator on the skull, that is a bony fixed part on the skull is demarcated by us. In if it is a if it is a head, then we demark occiput as the denominator, and when the uh, occiput is in the right part of the pelvis, so it is right occipital position. If it is in the left side, it is left occipital. If it is anterior, left occipital anterior, right occipital anterior, likewise. In the attitude of the fetus, attitude is of the fetus is relationship of fetal parts to one another. The attitude of the fetus at this point is, and near the term, it is of complete flexion. Flexion on all joints is adopted by the fetus. है ना? Neck is also flexed, the head is clenched, the hand is also like this. So all the whole of the fetus is, the attitude of the fetus is universal flexion. Okay. Now we will have to inspect first. When we start examination, the steps of examination are: first is inspection, another is palpation, then auscultation, then the vaginal examination, and on and so on. So first is inspection. In inspection, what we do is we just see, we just observe. We make the patient to lie on the supine position in a comfortable position with maintaining all the privacy of the patient. uh, before the patient shifted to the examination table, ask the patient to void the urine, preferably void the stool, so that we can get a correct information about the position, the presentation and the attitude of the fetus. Then in inspection, what we see is, just now I told you that there is uh, uh, pigmentation, है ना? Linea nigra can be very easily seen. So we can see the pigmentation on the symphysis pubis to the ensiform cartilage. Then there will be we will have to see the shape of the uterine ovoid, which is maintained up to 36 week. Okay. So the uterine ovoid is longitudinal or transverse or oblique, है ना? Then the shape on the contour of the uterus, fundal height, fundal notching is, if it is there or not. Then the skin condition. When we see the patients, is usually there are a lot of stretch marks on the abdomen, and if the dressing is not proper, if the patient is not keeping good hygiene, we can see the fungal infection also. Itching and fungal infections can be seen. So for that, we will have to see whether it is happening or not, and if it is happening, if there is some fungal infections on that particular area, we have to advise medicines and other methods of preventing these infections. So, and then see the incisional marks on the abdomen. if previous history of cesarean section, previous history of appendicitis or any other operation done on the abdomen, we can see, we will have to see the scar and see whether there is any possibility of herniation or not. So all these things are done in inspection. Now whatever we have seen in inspection, that is the longitudinal axis of the uterus we have seen. Okay. Now we will have to confirm it by palpation. Whatever information we have gathered in inspection is correct or not, we will have to confirm it by palpation. The next thing is, the next uh, uh, mode of examination is palpation. Now when we palpate, next slide please. In palpation, we put our hand on the abdomen of the patient. Okay, especially the ulnar border of our hand. We put, always we have to stand on the right side of the patient, and we put our both the hands on the fundus of the uterus. That is known as the fundal grip. Okay, you can see on the diagram itself, it is very clearly shown. In the fundal grip, what we palpate in between our both hands. Okay, what we see palpate in between our both hands, whether it is a globular hard ball. If it is a globular regular hard ball, it is head. If it is irregular bogey soft mass, it is breech. Okay, likewise fundal grip. Then we will have to bring our hand, which is on the fundus, we'll have to bring the hand little bit down around umbilicus, that is known as umbilical grip or lateral grip. When we do that, we feel the fetal back, the fetal parts on the another hand, and we see whether whatever information we can gather, we palpate the whole back, we palpate the fetal parts. Then again we will have to bring our hand down. When the third is, that is Paulic grip, the third Leopold grip, we have to use only one hand, and we have to overstretch the hand. ये क्या हुआ? Cancel नहीं होएगा. हाँ. So with the outstretched hand, we will have to outstretch the thumb and the finger, and we will have to keep this ulnar border of our hand on the symphysis pubis and hold the fetal part, whatever is coming in between your hand. Okay. Once you make hold on it, we just have to move it, whether the movement is possible or not. If it is moving, the head is not head has not crossed the pelvic beam, because once the head has entered the pelvic beam, we cannot move it. Okay, there is no room to move. But if it is moving, it is not entered, that is the engagement of the head has not done. Okay, and if it is not moving, it is fixed, then the head is engaged. Next is pelvic grip, or the fourth Leopold maneuver. In that, we again same like fundal grip, we will have to go for the grip that is in the pelvic side. So we will have to turn, and we'll have to again the same we can see on the screen, that the hands are kept, and we will have to palpate whatever is coming in between our both hands. In between our hand, if we have palpated soft, bogey, irregular mass in the fundal grip, so what we are going to see in the singleton pregnancy is the head. If the breech is up in the upper segment of the uterus, the head is going to be in the lower segment of the uterus. Now when we feel that the head is there in the lower uterine segment, what next we need information is whether the head is engaged or not. So when we put our both fingers and we push it down, and we try to converge both the fingers towards each other. If it is converging, a globular mass is coming on the hand and the fingers are converging, it is directing towards each other, that means the head is not engaged yet. And if even if you're with your efforts, the fingers are not approximating, or it is not converging towards each other, the head has entered the pelvic beam, and thus we can get confirmed about the engagement of the head. Next slide, please. Now the auscultation. In auscultation, if the head is down, we usually auscultate the fetal heart sound on the back of the fetus, on the scapula, especially the left one. So we will have to feel the back of the fetus, feel the anterior shoulder of the fetus, and put the stato on the scapula by palpating the uterus. Okay, and then count the beats. I told you about how will you differentiate between the uterine shuffle and the phonic shuffle or fetal shuffle, fetal heart sound. Phonic shuffle, and fetal heart sound, they are same. Even if you hear any one of them, it is not a big deal. The beating will be same. Normally the fetal heart sounds are 110 to 160 per minute. Okay. Then uh, if the head is down, we can feel the fetal heart sound below umbilicus near the midline. If it is a breech presentation, mane if the head is in the upper segment and breech is there, or the buttocks are there in the lower segment, then you are going to feel the fetal heart sound or auscultate the fetal heart sound in the above umbilicus near the midline. Okay, so fetal heart sound, where to hear the fetal heart sound is again a very tactful thing. Next slide, please. Next slide is about the engagement of the head. Engagement of the head. Just now I told you how to elicit the engagement of the head. Next slide, please. Inspection calibration. In this slide, we can very clearly see when the greatest horizontal plane, the bilateral, has passed the plane of pelvic beam, the head is said to be engaged. It is very nicely given in the diagram. When the head has entered the pelvic beam, it is engaged. Okay. Next. Uh, and if we find that the head is not engaged, especially in primary at the 38 weeks of age, and still the head is not engaged, so what are the possibilities? Okay, as it is very correctly said, say that head itself is a very good pelvimeter. When the head enter the pelvic beam, or if the engagement has occurred, half of the war has won. Na? Because head, when if in any cavity the head can enter, the whole body can come out of it. So head itself is a very good pelvimeter. So if the head is not engaging, there are some possibilities, there are some abnormalities which may be present. So if the head fails to engage at 38 weeks, there are some 38 or after up to in primary, especially 38 weeks needs to get engaged. The head needs to get engaged at 38 weeks. So if it is not engaging at the age of 40 weeks also, then these are the possibilities which can be there. That is deflexed head. If the head is not properly flexed, the diameters are not corresponding to each other nicely, and it fails to engage. Then cephalopelvic disproportion. If there is a big head and a small pelvis, so that can lead to cephalopelvic disproportion. Then the polyhydramnios. If the amniotic cavity is if the amniotic fluid is more in it, in the more than the normal quantity, much more room is available for the fetus to move, and because of that, the head may not get engaged, or the presenting part may not enter into the pelvic beam. So that is the polyhydramnios. Then poor formation or yielding of lower uterine segment. This is another entity. Then hydrocephalus, where the head is big because of large amount of uh, CSF fluid, and this is a congenital malformation, and because of that the head size is big, and that may hamper the engagement of the head into the pelvis. Then placenta previa, it is the lower uh, placement of the placenta. If the placenta is present in the lower part of the uterus, it will engage the diameter. The available diameter for the head to engage is less, and that may lead to non-engagement of head. If there is pelvic tumor, again the same thing, it will take more space. है If the pelvis has a tumor, so how can any other part will be entered into the pelvic cavity? High pelvic inclination, if there is sacralization or lumbralization, there is the angle of inclination will increase, and that may lead to delay in engagement of the head or non-engagement of the head. And if there are no other causes and still the head is not engaged, then it is called functional cause. There are no reasons, but still the head is not engaged. Next slide, please. Now, antenatal, in the antenatal care in the third trimester, about the antenatal care, we know that antenatal checkup is done at the interval of 4 weeks up to 28 week. Every month the patient has to come up to 28 week, and thereafter every 15 days she will be called for the antenatal checkup, and after 36 week she will be called every week. Okay. Then we have to advise the patient regarding the diet of the patient. We have to advise the patient regarding the ominous feature. In the last, after 36 week, when the patient came for ANC checkup, we tell her about the ominous features which may arise. That is, if the patient has to rush to the hospital, if she has leakage of fluid from the vagina, if she have abdominal pain or severe pain, if she is having little bit of vaginal bleeding, if she is having some headache or some visual disturbances, and if she is having some she is feeling lack of fetal movement, she'll have to report immediately to the hospital. And if she is having fever, chills, rigors, vomiting and diarrhea, she'll have to immediately report to the hospital, even if there is no due visits, but still any one of these feature or combination of two or three, the patient should rush to the hospital. Then in the ANC advice, we used to advise diet. This is a very important thing which we usually miss in ANC checkups. If the diet of the patient is good, there won't be any complication to the patient. If the diet of the patient is rich in fiber, protein, and all the ingredients which are necessary, calories, and all the things, the patient may not suffer from the minor ailments during pregnancy. So, this is a very important thing, that calorie requirement is increased to 300 kilocalorie over the non-pregnant state. In pregnancy, 300 kilocalories more should be added in the diet. The diet, what we usually do is we used to advise the patient to eat according to our need, but we should keep one thing in mind, that whatever the patient liking is there, according to that we will have to plan the diet and the affordability of the patient. Most of the time I see in the ANC checkup, they used to give one brochure to the patient, that eat cashew, eat badams, and eat almonds, and all the things. But she may not afford these things. So we have to provide some alternative to the patient, like groundnut, yes, pallidana and good, peanuts and jaggery. This is a very good combination. In our we advise in the low socioeconomic condition of the, if the patient is having low socioeconomic condition, she cannot afford cashew, but she can afford peanut. She can afford groundnut. she can afford jaggery. So likewise, we will have to advise the patient about the diet. Then antenatal hygiene should be properly maintained. In the antenatal hygiene, rest and sleep is the most important thing. The patient has to sleep for 10 hours per day. Okay, in afternoon 2 to 3 hours, 6 to 8 hours in the night, like that, in the lateral position. In the third trimester, the position of sleeping should be monitored very correctly, because if she sleep in the supine position, that gravid uterus will go on and pressurize the kidney, will go and pressurize the inferior vena cava and lead to so many ominous features. So you will have to advise the patient to sleep in the lateral position, whatever lateral position she may prefer, left lateral or right lateral. Then the uh, bowel habit should be clearly monitored. Ask the patient to avoid urine as well as stool, and it should be soft. If it is not soft, if the bowel habits are not regular, she may develop hemorrhoids, she may develop fissures, which are very we can say very painful as well as complicating thing, which can go and complicate her whole life. So we'll have to ask the patient for diet which is rich in fiber, and especially milk at bedtime will prevent constipation. Then bathing is done in regularly with clothing, shoes and belt all should be advised properly. Cloth, loose clothes, no belt, no tight belt along waist, no heels should be advised. Dental care is the most important thing which we should advise to the patient, that during pregnancy she should take care of her dentures properly, because uh, I usually tell my student that the pregnancy the fetus used to be a parasite to the mother. Although there is love and affection for the fetus to the in the mother, but still the fetus doesn't have that from the beginning. The fetus, if you are not going to supply the fetus the calcium it needs, it will drag the calcium from your teeth, from your bones, from the mother's teeth and mother's bones. So we will have to keep a close watch on the calcium level of the mother also, so that the teeth of the mother, the bone of the mother can be prevented. Okay. Then the dental care, caries of teeth are very common complication during pregnancy. Then care of breast. This is again care of breast. In care of breast, most of the doctors they don't advise anything during ANC checkup. But if we advise proper breast care during pregnancy, there won't be any cracked nipple or any retracted nipple after delivery of the baby. So the complications of lactations can be prevented by advising the uh, breast care properly. Breast care may I used to tell that while bathing, she has to clean the nipple and areola properly. She has to apply a little bit of oil and pull the nipple upward, so that retraction of the nipple can be prevented, and the dead skin surrounding the nipple can be taken out, and there won't be any cracked nipple afterwards. Coitus, it is not said that coitus is avoided during pregnancy, but yes, there is risk involved in it. Then travel should be avoided as much as possible. Smoking and alcohol should be strictly avoided. Immunization, any live vaccinations are avoided during pregnancy. Tetanus vaccination is done during pregnancy. As we know that tetanus vaccination has lifespan of 6 months. After every 6 months we will have to give tetanus toxide. So in pregnancy 2 times tetanus injections vaccinations were done. Then general advice like motivating the patient for ANC checkups, for lactation, and other instructions. Next slide, please. Regarding the investigation, sonography, and MRI and electronic fetal monitoring is advised. Next slide. Slide change नहीं हो रही. Next slide please. क्या करेंगे? Kiran madam, can you hear me? Thank you. Then the investigations. Next slide please. Next slide. In the minor elements, we are going to see that nausea, vomiting are there. Nausea, vomiting throughout pregnancy may not be felt by all the patients. In the first trimester, nausea, vomiting may be felt. But in few cases, we may have the patient may report of nausea, vomiting, acidity and heartburn, backache, constipation, and leg cramps, varicose veins, hemorrhoids, ankle edema and vaginal discharges. Now all these things, backache are due to ligaments. Kiran madam, can you please off your microphone? Hello, Kiran madam. Thank you. So backache is felt because the ligaments were relaxed in the third trimester. In the last part of third trimester, usually the ligaments were relaxed so that the room the nature is making available room for the descending fetus. There is constipation because the fetus has descended into the pelvic cavity and pressurizing the bowels over there. Then leg cramps, again because of the weight of the gravid uterus, the circulation in the lower extremity will be hampered a little bit and that may lead to leg cramps. Acidity and heartburn, it may be due to anxiety and because of the high level of progesterone. Then varicose veins, again because of the pressure of the gravid uterus. Hemorrhoids are because of the same thing. Ankle edema, again the circulation is hampered because of the gravid uterus. And vaginal discharge, a little bit of non-irritating vaginal discharge is going on throughout the pregnancy. It may increase in the third trimester. But if it is if it is accompanying some other features like itching, some backache and some feverish features, feverish symptoms to the patient, then it is an infection. We will have to tackle it with the drugs. Then the therapeutic part of it, the next slide please madam. Next slide. In the therapeutic part, we'll see the minor elements. We'll cover almost all the minor elements. Previous slide madam. Yes, thank you. So in this slide we can see the minor ailments, that is nausea and vomiting. Nausea and vomiting, if it came in the third trimester, one of the drugs which I love to prescribe in this ANC days are Symphoricarpus racemosa. This is a very good drug in ANC times. This drug is highly recommended for the persistent vomiting of pregnancy, gastric disturbances, and all the appetite, unloyal appetite or changeable appetite. And there is nausea, water brush, bitter taste in the mouth, there is constipation, nausea worse from motion, and better by lying on back. These are the and in my OPD as well as in the college OPD, we very frequently use this drug in ANC period. This is a very good drug. In Department of Ayush, when they have conducted one symposium on ANC checkup, ANC clinics, this drug was almost dominating all the other drugs told at that time. Then another drug is arsenic album, which is arsenic album is a drug of choice when there is excessive thirst and cannot bear the sight and smell of food. The patient craves milk, arsenic patient. And then there are some other drugs like cyclamen. In the cyclamen, the patient is having salty saliva anemic and chlorotic condition of the patient, hiccups like eructations. The patient used to complain that there is hiccup and then she feel nausea and vomiting. Hiccups and eructations, loud eructations followed by hiccups. So these all are the features. And desire for lemonade, satiety after few mouthful, no thirst all the day. All the day the patient will not have any thirst, especially in cyclamen. Then lobella inflata, another good drug of choice during for nausea and vomiting during pregnancy. There is acidity. There is flatulence during pregnancy. Most of the patient complains of flatulence during pregnancy. For flatulence, lobella inflata is a very good medicine. Sorry. Shortness of breath after eating, profuse saliva and heartburn, extreme nausea, vomiting, and there is morning sickness, a good drug of choice for morning sickness. Faintness, weakness in the epigastrium. Appetite is excessive. In lobella inflata, the appetite of the patient is excessive with a contractile feeling in the pit of stomach, profuse sweating, prostration, and flatulence is throughout the pregnancy. Throughout it is a common feature of lobella inflata. And if the patient is complaining of flatulence, the first drug should come in our mind is lobella inflata. Then the medorinum is another drug. Pernicious vomiting of pregnancy, coppery taste, eructations of sulfurated hydrogen. Sulfurated hydrogen is the flatulent which we pass, but that will come in the eructations. This is a classical feature of medorinum. There is ravenous hunger soon after eating. As the patient eats, she feel again hungry. Pulsatilla, dyspepsia with great tightness after a meal, must loosen clothing, and there is thirstlessness and flatulence. So these are the few drugs which we used to prescribe in nausea and vomiting during pregnancy. Then the next is backache. As I told you, the reason of backache, we should differentiate, or we should be able to differentiate whether this backache is because of the looseness of the ligaments or whether this backache is of labor pain. Severe backache in the last part of last trimester may be the labor pain. So we should be able to, that labor pain is, again it is easy to differentiate because labor pain is rhythmic, the frequency intensity will be like cyclic manner, and severity is more, there may be show, so all these things. But then backache, a dull backache in the last trimester can be very easily tackled by Aesculus hip. Aesculus hip is a very good drug. Region of spine feels weak and back legs gives out. Backache affecting sacrum and hip, worse by walking and stooping. Patient is unable to stoop in the last trimester, and if the backache is aggravating after walking, it is Aesculus which can be prescribed. Kali carb is another drug of choice for backache during pregnancy. Severe backache during pregnancy, especially the lumbosacral region. Lumbosacral region will feel severely painful, and burning in the spine will be there. There will be numbness in the extremity. Limbs go to sleep easily, tearing pain in the limbs sensitive to pressure. And other Kali carb can be prescribed in nausea, vomiting, in heartburn, acidity. Kali carb is a very good drug of choice during pregnancy. When there is epigastric pain radiates to the back. When anxiety felt in the abdomen, when there is excessive craving for sweet, and excessive acidity can be very nicely tackled with Kali carb. Then the next drug of choice for backache is bryonia, stitches and stiffness in the lumbar region. Rustox is another drug. In bryonia, movement will aggravate the condition, and in Rustox, first movement will aggravate, while the continuous motion or movement will produce amelioration to the backache. So in Rustox, pain and stiffness in the lumbosacral region, better by motion or lying on something hard, worst while sitting. Staphysagrina is another drug of choice for backache during pregnancy. Backache worst in the morning. When the patient rises from the bed, patient will feel severe backache. That is Staphysagrina. dull aching of the nads extending to the hip joint and lumbosacral region. So this is about the backache. The next, there are other drugs also, but these are the common drugs which we prescribe. Then constipation. In constipation, cholinsonia is very good drug. Constipation as well as for hemorrhoids. Cholinsonia is the drug of choice during pregnancy. In cholinsonia, constipation में dry feces, sensation of sharp sticks in the rectum. There is obstinate constipation during pregnancy with protruding hemorrhoids. Then the next drug is hydrastis, constipation with a sinking feeling in the stomach with piles. Then lacasis is another drug for constipation. There is offensive stool. Anus feels too tight. Even the patient is unable to pass anything. Anus tight as if nothing could pass through it. Then lycopodium. In lycopodium there is inactivity. Inactivity of intestinal canal, ineffectual urging, stool is hard, difficult, small, incomplete hemorrhoids, incomplete and hemorrhoids. In nux vomica, is, as we all know, nux vomica is definitely a very good drug for all the gastrointestinal problems, whether it is felt during pregnancy or in non-pregnant state. But in pregnancy there is a frequent ineffectual desire to pass stool. A little bit of stool is passed and the patient feels that again I have to go and void the stool, again I have to go and void the stool. A complete satiety will not be attended in nux vomica. So there is weak constipation with frequent ineffectual urging and incomplete and unsatisfactory feeling as if a part remained unexpelled. Irregular peristaltic action, hence frequent ineffectual desire for passing stool and small quantity at each attempt. Platina for constipation in pregnancy, stool is retarded, scanty feces, evacuation with difficulty, sticky stool which adheres to the rectum. It is difficult to pass. Then in sepia there is great tenesmus. In sepia, when there is great tenesmus and there is a sensation that ball-like thing is obstructing in the rectum, and the patient is bears down to pass stool, but she cannot bear down because there is a lot of tenesmus, lot of pain felt. So constipation, large hard stool, sensation as if a ball in the rectum, cannot strain with great tenesmus. These all are the drugs for constipation during pregnancy. Then the leg cramps, which uh, cramps can be very nicely tackled by asking the patient to drink one or two glass of juice, because in juice is an ideal combination of electrolyte, vitamin C and water. So by giving some home tips we can manage these leg cramps, but if the patient is not relieving we can give the drugs. They can be seen on the screen, like calcarea, chamomilla, colocin. So calcarea, when to give calcarea? When there is cold damp fit, patient feels as if a damp stocking were worn and there is cramp in the calf muscles. Chamomilla, the patient is irritable and all the things of chamomilla will be there in this also. Violent pain drives patient out of bed at night, compelled to walk around, burning in the soles at night. Then the colocin, in colocin, contraction of muscles, cramp like pain in hip, uh, lies on affected side. Muscle and tendons feels too short. Then the next drug for leg cramp is cupromet. Cupromet is very good drug of choice in all the muscular problems. But cupromet is very good drug for eclampsia also. So cupromet cramps in the calf and sole. Here we are dealing with the leg cramp, so a good drug for calf cramp and sole cramp. Then diascoria is another drug, cramps in the flexor of finger and toes. Lycopodium, cramp in the calf and toes at night in bed and limbs goes to sleep. Numbness of the limb, and the patient suddenly gets up at night and she feels that suddenly severe pain is felt. So for that we can give lycopodium. Magphos, the characteristic feature of magphos is better by hot fermentation. So whatever weakness and arms are cramps are felt by the patient, it is relieved by hot fomentation. Then MAC pause can be thinking of, thought of. Weakness of arms and hands, cramps in the calf, general muscular weakness can be very nicely tackled with MAC pause. Then sulfur is another drug of choice when the patient cannot stand. Standing is the worst position for sulfur. So standing is the worst position, burning in the sole of hands at night. So this is about the leg cramps. Then acidity and heartburn. In acidity and heartburn, most of the drugs of nausea and vomiting will come, but there are few other addition of few more other drugs like acetic acid. In acetic acid, there will be profound anemia, vomiting, specially indicated in pale, lean patient with lax flabby muscle. There is salivation which is excessive, thirst, intense thirst, intense burning thirst, and there is epigastric tenderness in acetic acid. Then diascoria. Diascoria is definitely a good drug of choice in hyperchlorohydria. Mouth dry, bitter in the morning, there won't be any thirst, belching of large quantity of offensive gas, pain along the sternum, extending to the arms. This is a classical feature of diascoria. And another classical feature of diascoria is pain which is felt in the abdomen is better by bending backward. When the patient goes backward and feels better, then it is diascoria, and when the patient gets double up for relief, it is holosynth. Okay. Then MacCarb. MacCarb is it is one of my favorite drug for acidity. MacCarb is marvelous drug. When we give with its indication, it acts within minutes. The patient will be relieved. In MacCarb the indications are mouth dry at night, sore taste in the mouth, desire for fruits, acids and vegetables. See, sour taste is there in the mouth, but still the patient desire for fruit, acids and vegetable. Eructation sour with vomiting of bitter water and craving for meat is there in MacCarb. Nux moscata, I told you about the toothache during pregnancy. For toothache during pregnancy, Nux moscata is a very good drug of choice. Very dry mouth of in the Nux moscata, extremely dry mouth. Tongue adheres to the roof of the mouth. So much of dryness. But in spite of so much of dryness, the patient doesn't want to drink water. There is no desire for water. Stomach excessively bloated with flatulence, dyspepsia and hiccups. Tabacum is another drug for acidity and water brush. Incessant nausea, worst small of back, worse by smell of tobacco. This is a characteristic feature of tabacum, that if the patient is traveling and some passenger is smoking, the patient cannot tolerate that. She'll go and ask him to stop the smoking. This is a classical feature of tabacum. Worst smell of tobacco. Vomiting on least motion, sometimes of fecal matter during pregnancy with much spitting. Both excessive salivation will lead to much spitting. Then for hiccups during pregnancy, cyclamen is drug of choice. Again, cyclamen I explained in the beginning that there is salty taste, hiccups like eructations, worst after fatty food, satiety after a few mouthful only, and desire for lemonade and no thirst at all. Cyclamen and pulsatilla, they don't have thirst at all. But in pulsatilla has desire for open air, which is not there in cyclamen. The second drug of choice for hiccups and acidity and water brush is opium. Mouth dry, tongue black, thirst intense, hiccups with vomiting, colic, hungry and no desire to eat. Then the next slide please. Varicose veins. Another is entity which we usually come across is varicose vein. One of my case I think I can never ever forget is varicose veins in the vagina. I have seen one patient, one allopath referred it to me. They don't have any drug for varicose veins in vagina or varicose veins for Allopath don't have much drug for it. They advise so many mechanical things and they advise surgery, but they have the limitation. They don't have drugs for varicose veins, but we have very good drugs for varicose veins. I have treated that case of vaginal varices with success within 1 week, and the patient delivered through vagina. The doctor has given me lot of compliment for it, and because of that I can never ever forget that case of mine, varicose veins. So varicose veins are very common entity which we come across during third trimester. The drugs are my commonest drugs which I used to use in my OPD is Hemamelis and Pulsatilla. But while preparing for this lecture, I gathered so many drugs, and I also have enhanced my knowledge for treating varicose veins during pregnancy. APC is one of the drug. Stinging pain with edema of feet, hives with intolerable itching. Carbovage is another drug for varicose veins. Blue, cold ecchymosed varicose veins, over distended. Hot perspiration, varicose ulcers and carbuncles can also be covered by carbovage. Then venous congestion, hemorrhage, varicose veins, hemorrhoids and bruishes, soreness of affected parts seems to be the special fear of this remedy, and painful varicose veins are very nicely tackled with the hemamelis. Tired feeling in arms and leg will be there in the hemamelis, which is very common feature in pregnancy. Pulsatilla, bearing down pain in the boring pain in the heel towards the evening, suffering worse from letting the affected part hang down. When the patient hangs down her limbs, the patient will feel excessive pain. This is a classical feature of pulsatilla in varicose veins of pulsatilla. Veins of forearm and hand swollen, feet red, inflamed, swollen legs and heavy, swollen varices, legs heavy and weary. Then zinc met is another drug. Large varicose veins on legs, sole of feet, sensitive, sweaty feet, and as the characteristic feature of zincum is feet-getty feet. The feet are continuously in motion. Then there are, next slide please. There are another like hemorrhoids. For hemorrhoids we have muriatic acid, nitric acid, sepia, and we have for prolapse of rectum. Yes, I missed one, prolapse of rectum. Podophyllum is the drug of choice for prolapse of rectum. Prolapse of rectum before or with stool, internal and external piles, hemorrhoids with prolapse ani during pregnancy, prolapse from overlifting or straining during pregnancy. This is, I have used this drug for uterine prolapse with great success, and uh, but in book it is written that it is a very good drug for rectal prolapse. So podophyllum should be remembered for prolapse of rectum. Then edema, for edema there is apis, and there are so many drugs which are given. Antimcrude, apis, arsenic, china, digitalis, helleborus, merc. Then for vaginal discharge, as I told you that there is a non-irritating vaginal discharge throughout the pregnancy, but if it is accompanied with itching, that is pruritus, if it is having some offensive leukorrhea, offensive discharge, then creosote, then umbra gricia, caladium, sepia and colinsonia are very good drugs. Then sleepiness during pregnancy, which I have missed in the slide. Sleepiness during pregnancy, for sleepiness during pregnancy, coffea, Naxomica and Passiflora are the drug of choice. Sleeplessness during pregnancy. Because of anxiety, because of lot of stress during pregnancy. In India, we all know that if the lady is pregnant, the people around the lady used to tell, oh, your next incarnation will be there after delivery of a baby and all. So that will put lot of burden on the brain of the lady, and she may get anxiety, and she may get sleeplessness. So coffee and naxomica and passiflora are a good drug of choice for sleeplessness during pregnancy. UTI, which we come across during pregnancy very commonly. UTI, there are lot of medicines in homeopathy like Cantharis, Berberis, Variolaris, Sarsaparilla, Thuja, Merxol. So many medicines are there. Then we'll see the complications which can be commonly seen during the third trimester, that is gestational diabetes, preeclampsia, preterm labor, premature rupture of membrane, antepartum hemorrhage, IUGR, intrauterine growth retardation, post-term pregnancy and malpresentation. All these entities can be not almost all, but few of them can be very nicely tackled with the homeopathic medicine. Next slide, please. In the next slide, for gestational diabetes, we have very beautiful drugs for gestational diabetes. We have acid phos, we have Syphilendra, we have Gymnema sylvester, we have Syzygium, Jumbolinum, and Uranium nitricum. For gestational diabetes, next slide, please. For gestational diabetes, we can very nicely prescribe, because this diabetes is going to stay only during the gestational period. So instead of going for allopathic medicine, the patient usually asks us to prescribe medicines, and we have really very good medicine. I have very good results. This is my personal experience, which I wrote over here, that Syphilendras, Gymnema, Syzygium, and Uranium nitricum. Then the preeclampsia. For preeclampsia, Epis, Belladonna. I'll not go in explaining those drugs because the time will not permit us. As well as I have already covered most of those drugs in previous topics. So we will just go through the names of the medicine. For preeclampsia, Epis, Belladonna, Ferrum, Glonine, Calichloricum, Califos, and Lycopodium. Then eclampsia, if the preeclampsia is complicated with convulsions, it is eclampsia. For eclampsia, all the epileptic drugs of homeopathy, Cicuta, Cuprumate, Helleborus, Belladonna, Hyoscyamus, Passiflora, Stramonium, Strychnine, Veratrum, Viridi, etc. Then for antepartum hemorrhage, Arnica, Belladonna, Calcarea, China, Crotallus horoides, ferrum, hemamelis, millefolium, nitric acid, phosphorus, pulse, sabina, cichlicore, and trillium are the good drug of choice. For IUGR, next slide, please. In case of IUGR, we can prescribe all the antisyphilitic drugs which we have in our materia medica. They are Merck, sulfur, syphilinum, thuja, tuberculinum. Then post-term pregnancy. For post-term pregnancy, when there is, see in IUGR, Merck, sulfur, syphilinum, thuja, and tuberculinum. Then in post-term pregnancy, Colophilum and Pulsatilla. If the pains are deficient, depending upon the indication of the patient, we can prescribe Colophilum or Pulsatilla. For malpresentation, see in allopathy, for malpresentation, we don't have much drug, or we don't have a drug at all. But we have drug in homeopathy, that is Pulsatilla. Pulsatilla is the drug of choice for malpresentation, and I have so many cases of correcting the malpresentation by giving Pulsatilla. So I think I have completed with my presentation. Thank you.
Well, thank you, ma'am. It was an excellent presentation with good comparisons being done related with all the remedies in terms of the overall, if at all they speak up, it is right from the first trimester to the third trimester. But
Yes,
well elaborated explanation and comparison being given for the remedies related to the third trimester of pregnancy.
I have
I
tried.
request any participants, if at all any questions, you
Yes,
can
please.
please put up in the chat box. Ma'am, just we'll wait for 2 minutes if at all anybody has any questions.
Yes, yes, definitely. If the questions
Ma'am,
will be
one
there,
question
I'll
is
be.
already
Huh.
been put up.
Uh-huh.
One question is being put up by one of the participant telling
Yes.
that I have a IBS during pregnancy and which medicine will be of use.
For irritable bowel
I
syndrome
have a
during pregnancy.
during pregnancy. So what
Yes, yes.
medicines can be used up through homeopathy?
Uh, Aloes, Mercor. Aloes is the drug of choice for IBS, for usual patients of IBS in non-pregnant condition also. And it doesn't matter for homeopath if the lady is pregnant or not. If even if she's pregnant, even if she is not pregnant, we will give the drug which is matching to the indication of the patient. What are the symptoms of the patient? We will have to gather it first, and then we can prescribe. So aloes, Mercor, there are Nux vomica, and all the drug which we used to give for loose motions, we can give for IBS during pregnancy also.
Okay, ma'am. One more question has come up
Yes.
is about a little bit more explanation on how pulsatilla can cure the malpresentation. Because that's the routine questions also which the
Yes.
students get it
Ah,
related to pulsatilla and kalikap
ah,
in terms of malpresentation. So what will be the
malpresentation.
role of these remedies in malpresentation?
In malpresent, we exactly don't know the cause, but when we study the physiology, uh, why head used to come down? If we understand this physiology, why the head used to come down? The nature itself, from the very beginning, brain is the first thing which starts development. So the thing which has developed to its most extent with the heavy skull on it, and if there is fluid and we put a heavy thing down and a little light thing up, so the heavy thing will go down. So it is a physiology. It is because of this physiology, the head in the amniotic fluid, the head is heavy, and because of that, the head will come down. Okay. So when the and what homeopathy do? When we prescribe homeopathy, it will help the physiology to work upon. Thus, it helps in changing the position of the baby.
Uh, Thank you, ma'am. It was a better explanation which was
Yes.
needed.
Yes.
One more question has come up, ma'am,
Hmm.
is about in pregnancy, can you tell me the indications of pulsatilla in third trimester? Is it advised to be given for easy delivery?
Yes. Yes.
I repeat,
Frequently the patient, yes,
indications of pulsatilla in third trimester.
indication of
Is it
pulsatilla in.
advised for easy delivery?
Yes, it is very frequently advised for easy delivery, and the patient symptoms compel us to prescribe pulsatilla most of the time. It's my personal experience which I am sharing with you. Is the patient used to come with emotional disturbance, desire, long dyspnea will be there, desire for open air will be there. The patient will become very emotional. Patient becomes thirstless, and uh, for easy delivery, yes, pulsatilla does help. It is
Oh,
written in the
that's
Materia Medica also that pulsatilla helps in the enhancing the labor pains and bring about uh, the labor pains are slow, feeble, and weak, spasmodic, ineffectual, irregular, changeable pains accompanied by smoothing, desire for open air, fainting, and there will be thirstlessness. So depending upon these symptoms, we can prescribe. My experience to after some years of practice, experience will be more reliable criteria than the materia medica, I feel. Of course, we will have to consult the materia medica. The highest court of appeal is materia medica. So we have to go and see the symptoms and whether it matches to the patient or not. But most of the patient used to come with the symptoms of pulsatilla in the last trimester, especially the last days of last
uh,
trimester.
thank you, ma'am. One more question is being asked related to belladonna in
Hmm?
pregnancy. It's
Belladonna.
been said that belladonna advised to be given in pregnancy, as it is been heard that it brings about abortion.
No.
So what is true about it, ma'am?
Uh, uh, See, homeopathy can never ever hamper physiology. It will enhance the physiological changes. So, if you give belladonna in high potency in repeated doses, then it may cause some deleterious effect. But if you give in minimum single dose and matching the symptom totality of the patient, it will not cause any harm to the patient. Homeopathy is perfectly and clearly safe drug for pregnancy. Any drug which is there in the materia medica can be prescribed if it is indicated during pregnancy without any risk. Not only belladonna, any drug, because homeopathy will never ever uh, uh, disturb the physiology, and pregnancy is a physiological phenomena. So no drug will affect pregnancy. Homeopathic drug will affect the pregnancy.
Yes, ma'am. I hope your explanation would have been satisfied to the person who has put up the questions.
Yes.
One last question is there
Yes.
is, ma'am, if we are giving homeopathic medicines for complaints,
Uh-huh.
then there is no need to use any other medications like allopathic drugs.
Yes.
Any other conditions may need allopathic drugs? That is the question. Like the
Uh,
question is,
hmm?
if homeopathy medicines are given, is allopathic drugs needed? Or is
No.
it to be given for like any specific conditions?
Uh, See, for what exactly you are prescribing homeopathic medicine? If it is nausea and vomiting, so if you give homeopathy, there is no need of allopathic medicine. If the patient is already on allopathic medication and if you are giving homeopathic medicine, you can give. There is no contraindications that homeopathy can be given, only homeopathy can be given, no allopathy should be given. Not like that. We can prescribe both the drugs. We cannot prescribe allopathy, we can prescribe homeopathy only. But uh, for what entity we have prescribing, we should be clear for that.
Ma'am, two, three members have given up the same question is
Huh?
about the selection of potencies in the third trimester of pregnancy. Like
Yes.
it's an open question, not about
Huh.
specific with any remedy,
Yes, yes,
just
yes.
only about the potencies in the third trimester of pregnancy.
Potency selection depends upon the susceptibility of the patient. In our posology, it is written that potency selection is based upon the susceptibility of the patient. And susceptibility in pregnancy is quite high. So, uh, accordingly, we can prescribe. I used to prescribe 30, and in some cases, if needed, 200, not more than that. It is not needed in pregnancy also. We have to follow the law, the rule of ordinance for prescribing in pregnancy also.
Uh, I hope we have ended up with the questions.
Yes.
As such, no new questions, and that will bring us to the end of our session. And thank you, ma'am. We'll
Thank you.
just 2 more minutes, ma'am. Just two more
Yes, yes,
minutes.
yes.
Now,
Felt good, madam. Lot
uh,
of questions were
for
asked, and that's why I felt very good that the peoples are attentive during the session.
that's necessary, ma'am. Otherwise, it will be of no much of use then.
Yes, yes.
Uh, Dear participants, uh, now that we have come to this end of the session, if still you people do have any questions, you people can put up directly on the mail IDs so that your questions will be directed to the speaker and once again referred back to you. So if any questions still you get it, you can put it directly to the mail on the registration form, the mail ID what we have got it from guest lecture. On the same mail, you can put back to your questions and we will proceed ahead to give you the proper answer. Now that we have come to the end of this session of today's webinar, an important announcement has to be done is related to the next webinar in our series, which will be conducted on 18th of November, Wednesday, the timing being 3 p.m. to 4 p.m. on the topic Synthesis, Evaluation of Case Taking and Homeopathic Management, which will be conducted by the Department of Homeopathic Medica of Yenepoya Homeopathic Medical College. I request all the participants to please do register and attend the webinar, as the speaker is Dr. Ismail Seth, one of a renowned speaker in terms of homeopathy, who gives a better explanation about his personal clinical experiences. So I request all the participants to do the registration once again for the next webinar to come up, and hoping that your knowledge will be enriched as and how the webinars move ahead. So coming to the end of the session, the feedback link has already been given on the chat box. Please fill your names and the valid email ID in the feedback form, as the same will be taken for the certificate of participation. Now, important point is, dear participants, please make a note. These certificates are auto-generated. So, do take care to give the prefix as what you need it on your certificate. And also, please check to the spellings as well as your mail ID before submitting the feedback form, because like routinely we are hearing that either the certificates are not being received, or might be there are errors in the certificates with the spellings. But please take care about you people giving a proper feedback form. And that comes to the end of the session. Once again, if necessary, a feedback form, the feedback link is being put up on this slide, which will help you to recollect the same. You can take a screenshot and immediately put up the same. And now, coming to the end of this session, I request the Vice Principal of Yenepoya Homeopathic Medical College and Hospital, Narayana, Mangalore, Dr. Vijayendra V. Itigi, Professor, Department of Medica, to just give a vote of thanks for the speakers as well as for the participants. Over to you, sir.
On behalf of Yenepoya deemed to be University, Yenepoya Homeopathic Medical College and Hospital, Department of OBG, we extend our thanks to Dr. Harsha Kantode Madam to giving us knowledge on the third trimester and its role in the homeopathic management. I extend our thanks to Dr. Bhagya Madam, Yenepoya deemed to be University, for giving as a coordinator of this national webinar. I extend our thanks to our coordinators as well as our dean for his continued support, Dr. Shilpi ma'am, Dr. V.V. Varnekar sir as the dean of Homeopathic Medical College, and Dr. Kiran madam, and the participants as well as the teaching faculties. I extend my thanks to all our teaching technical supports, IT sections, Mr. Tamim, and staff, Dr. Ashna, Dr. Shishrut, and Dr. Jinu, for continued support on this webinar. Thank you one and all.
Hello everyone. The registration link for the next webinar is already been put up in today's chat box itself. You people can please refer to the same. Otherwise also, it will be mailed to you. It will be given to you tomorrow also. But at the moment, you people can register as and how you are going to give the feedback also. So both the links are there. Do take care to see up what you are going to enter up. Thank you one and all. Thank you, ma'am. Harsha ma'am. Harsha ma'am, you are there?
Ha, I am here,
Uh,
madam.
Thank you, ma'am.
Thank
Thank you,
you.
ma'am. It was literally a wonderful session, a good interaction. Even being in this department, it is nice to know something from other side also,
Yes,
and that enriches our knowledge. It helps us in our teaching also. So it was a good session for me, even after such a long period of teaching part. But we feel that we are going to keep on learning. It was a good
yes,
session, ma'am.
we.
Thank you, ma'am.
Thank you, madam.
Thank you, ma'am. Good day, ma'am.
Thank you.
Thank you, all the participants.